In the recent 2023 ESC guidelines for acute coronary syndrome, the abbreviation ACS was rechristened to indicate the strategy for triage and assessment of a patient of suspected acute coronary syndrome. A stands for abnormal ECG, C for clinical context, which is assessed by a targeted history taking, and S for stability, which is assessed by a targeted clinical examination. How these three components may be amalgamated to decide the approach in a patient of suspected acute coronary syndrome is illustrated by these two cases of chest pain with dyspnea, raised JVP, and clear chest. The first is a 50-year-old male who presents with acute onset severe chest pain and vomiting, followed by dyspnea for 3 days, while the second is a 55-year-old female with mild chest pain at the beginning, followed by dyspnea for last 4 days. Both have a raised JVP and clear chest with low BP. While the first patient has a pulse rate of 50 per minute and a respiration rate of 20 per minute, the second has a pulse rate of 120 per minute and a respiration rate of 44 per minute. Clinical examination reveals that the first patient has a raised JVP as evident from the distended external jugular vein that is pulsatile, but he has a normal respiratory rate, whereas the second patient also has a raised JVP, but she is tachypnic and appears to be more unstable than the first. A comparison of the ECG of the two patients reveals some important differences. The first patient has 2:1 AV block with ST elevation in lead 2, 3 and AVF with reciprocal ST depression in lead 1 and AVL, as minimal ST elevation in V1 and R by S pattern more than 1 in V2 with ST depression and upright T in V2, V3 to V6. So this is a case of acute inferior posterior wall ST elevated MI. The second patient's ECG shows some inferior lid changes that might tempt us to think of an inferior wall MI, but the combination of sinus tachycardia, T inversion in inferior lids plus V1 to V3, and poor R wave progression leading to a delayed transition of the QRS complex together strongly suggest a diagnosis of pulmonary embolism. The X-ray of the first patient shows right-sided pleural effusion, which is consistent with heart failure, and the second patient there is possibly some right atrial enlargement. But there is no pulmonary parenchymal abnormality or pulmonary venous congestion indicating that left heart dysfunction is not the cause of breathlessness in either patient. Echocardiography resolves the diagnosis. The first patient's echocardiography shows a hypokinetic basal IVS with right atrial and right ventricular dilatation and bowing of the IAS to the left. There is severe tricuspid regurgitation and there is akinesia of the RV free wall with preserved contraction of the RV apex known as McConnell's sign. The posterior wall and the inferior wall of the left ventricle are hypokinetic. The tricuspid annular plane systolic excursion is reduced, signifying RV dysfunction. Here you can clearly see the akinetic RV free wall with preserved contraction of the RV apex also seen on the subcostal view. The inferior vena cava is dilated without any respiratory variation because of severe TR as well as heart failure. On the other hand, the second patient deteriorated and had to be intubated. This bedside echocardiography shows right atrium and right ventricular dilatation with akinesia of the RV free wall and preserved contraction of the RV apex known as McConnell's sign, but the most dramatic finding are the thrombi moving in and out of the right atrium and right ventricle, confirming the diagnosis of pulmonary embolism. The first patient underwent coronary angiography, which revealed an occluded right coronary artery. The right coronary artery was stented, sinus rhythm was restored, and the RV function gradually improved. The patient was discharged in a stable condition. However, the second patient deteriorated rapidly. She went into cardiogenic shock. She was intubated and received anticoagulation inotropes, but in spite of all resuscitative measures, she succumbed. These two cases illustrate the importance of the ACS approach in a patient of chest pain. An abnormal ECG should be interpreted according to the clinical context, and therapy should be instituted depending on the stability of the patient. A relatively stable patient may allow a thorough workup and analysis before treatment is instituted, but an unstable patient should receive aggressive treatment, in spite of which the outcome may unfortunately not always be favorable.